Please keep in mind that this podcast deals with advocacy issues, and due to the nature of shifting legislation, this content may be outdated. Healthcare policy will always be a critical matter of any political candidate's platform. Once elected, representatives can make their mark on the healthcare landscape going forward.
Late in this election, one thing that emerged is healthcare was a very, very important issue. It grew in importance to voters throughout the cycle and kind of peaked right about Election Day. And exit polls really confirmed this also. Gallup's midterm election tracking polls showed that healthcare was the number one issue on voters' minds. That was even ahead of the economy, immigrations, gun policy, taxes, and every other issue they polled.
That's Todd Askew, AMA Director of Congressional Affairs. On this episode of Moving Medicine, a podcast from the American Medical Association, Mr. Askew recaps results from the midterm elections. We also hear from Richard Deem, AMA Senior Vice President for Advocacy, with a review of what those results mean for future healthcare policy. I'm your host, Todd Unger, Chief Experience Officer at the American Medical Association. This episode of Moving Medicine is one of two parts on the AMA's advocacy and policy work in 2018 and our look ahead to 2019. This speech was presented at the 2018 AMA Interim Meeting. Here's Todd Askew.
What I'm going to do is go through a little bit about recapping what happened in this election, and Rich is going to come up after me and talk about what this means for healthcare policy going forward into the next Congress. Especially late in this election, one thing that emerged is healthcare was a very, very important issue. It grew in importance to voters throughout the cycle and kind of peaked right about Election Day. And exit polls really confirmed this also. Gallup's midterm election tracking polls showed that healthcare was the number one issue on voters' minds. That was even ahead of the economy, immigrations, gun policy, taxes, and every other issue they polled. So voters went to the ballot box thinking about healthcare. Democrats were even a little more fired up about healthcare, with 87% of Democrats saying that it was extremely or very important to them about how they voted. But even 72% of Republican voters ranked it the same way. And so among those that considered themselves healthcare voters who were there voting on healthcare issues, these were the four general areas that they ranked as the most important: cost, access, coverage, and that includes Affordable Care Act, preservation of, and Medicare issues. And you saw these issues play out both at the federal level and at the state level. And it's kind of ironic in that in 2010, Democrats did not want to talk about health care. They had just passed the ACA. There was a lot of discontent. They ran away from the issue, and they got slaughtered. This year, Democrats embraced it as people have come to understand the value of the ACA and what Medicaid expansion has done in so many states for coverage. And they embraced it this year and saw a big legislative benefit from that. And Tom Davis, who's a former congressman from Virginia and former NRCC chair, has observed that the one thing they know about health care is that if you're disruptive, you lose. People prefer stability. Two of the big issues that came up during the election were both pre-existing conditions and Medicare for all. The Democrats rather successfully tagged a lot of Republican voters as opposing or trying to get rid of pre-existing condition exclusions. There is some truth, there is some exaggeration, hyperbole in those charges, but it was a successful effort. And unfortunately, a lot of Republican candidates, they didn't have a lot to point to counter that. I mean, they signed some non-binding resolutions that were all for pre-existing condition protections, but at the end of the day, they had ongoing litigation, they had votes to repeal the ACA, they had administration actions which undermined pre-existing condition coverage exclusions or protections, and so it was difficult for them to successfully make the argument. And so Democrats really went after him on it. And at the same time, Democrats on caucus was tearing itself apart internally about Medicare for all, single payer, whatever you want to call it. So Medicare for all was advanced primarily Senator Sanders and his supporters pushed a lot of Democrats into this. A lot of Democrats signed up. They said, yeah, I'm for that, because they didn't want to get primaried from the left. And then as we came back to the general election, they realized, well, there's a lot of people out there that aren't comfortable with the concept, because the Sanders proposal is not Medicare for all. The Sanders proposal ends Medicare, essentially. It makes it a single-payer system. It completely changes everything. So people started talking about other things. Well, I'm for public option, right? I'm for Medicare buy-in. And they never really got beyond down to what that really meant. There was some ambiguity in that. So voters saw in those statements what they wanted to see. Pro-single-payer voters said, hey, they mean single-payer. Anti-single-payer people said, well, they just want to offer us another option to purchase health insurance. And so it became a very difficult thing to tag a lot of Democrats with. At the end of the day, though, those that really staked their campaign on Medicare for all, single-payer, lost. 90% of people who featured 90% of candidates who featured single-payer or Medicare for all as kind of their prime thing did not get elected. So a lot of people have speculated that that is a dead issue. Probably not. We're still going to have to watch this very closely and take efforts to talk to people about what it means, but it is definitely something that did not carry the day during the last campaign, during this last election. Another big issue, though, was Medicaid expansion. 13 states have not expanded Medicaid. It became a ballot issue in 4 states and a featured issue in a lot of governor's races. Mostly those proponents of Medicaid expansion were successful. You had 17 states, or the number of states that had not expanded, saying 13, I believe, looking at, well, the feds pay 93% of the cost. And that's our tax dollars going to Washington and not coming back to us. They also know that the lowest it will go, at least in 2020, I believe, is 90% federal match in perpetuity. And so voters started to think that is actually a pretty good deal. It was successful in Utah, Idaho, and Nebraska. It did fail to extend the expansion in Montana, but I think that probably had more to do with the financing mechanism that had been proposed as opposed to the merits of Medicaid expansion. It was a featured issue in several governor's races, including Georgia and Florida, which are obviously both officially unsettled at this time, but Kansas and Wisconsin as well, where the proponents of Medicaid expansion prevailed. A big impact next year will be committee leadership structure. There are not a lot of new faces here. They're just kind of going to have new responsibilities. Senator Grassley, though, is an oversight guy, and so if he does return to finance, I think you will see a lot of oversight of federal health care spending programs and a lot of other issues as well. I would highlight one other. Richie Neal, Massachusetts, will be presumptive chairman of the Ways and Means Committee. Richie Neal is a moderate. He's a pro-business Democrat. He works very well across the aisle. And I think Kevin Brady, as chairman during this current Congress, really respected the role of the minority in that process to the extent that he could. And I think Mr. Neal is going to want to repay that and try and work in a bipartisan way to see what can be accomplished. Last thing I want to do is talk just very quickly about kind of some general buckets that they may be looking at in terms of governance. The first of these is very aggressive oversight. There's been a pent-up demand from Democrats to look at a lot of issues, a lot of both federal issues and issues in corporate governance that the Republicans have not paid much attention to. And so you already see a lot of presumptive chairman coming out in the last few days and outlining an aggressive oversight agenda. And so that will definitely be something they pursue. But obviously, the danger there is you overplay your hand and you look like you're just being completely political and not interested in getting anything done. They will work to try and reverse some of the deregulatory efforts of the Trump administration and some of the efforts they've made on the ACA. But without control of both chambers, They have very limited ability to do very much there. Again, that's a lot of addressing the pent-up demand within their caucus to stop some of these more than actually being able to do much. There are a handful of things that could potentially pass that are important to get done. Infrastructure, prescription drug pricing in a fairly limited way, and trade deals obviously are all priorities that have some support on both sides of the aisle. So it'll be interesting to see how that plays out. There are the base issues where there's probably not going to be a lot of bipartisan comedy on some of these issues, but they will be focused. H.R. 1 is going to be an ethics and campaign finance reform package that presumptive Speaker Pelosi, we'll just go with that for now, puts up. Guns, voting rights, Medicare for all, they're going to have hearings and play to that part of their base, and a number of other issues that will be very popular. So that's kind of the big picture category, but there are obviously a lot of healthcare policy things that are going to need to be addressed during the next couple of years. So I'll turn it over to Rich to talk about those.
Thank you, Todd. Good morning, everybody. First, I want to start with the comment that we have a lot of policy, and where we have gaps in policy, George has conference calls with the Council of Legislation, sometimes a couple times a month, as need be. If we need to go on the phone more than that, they do, to help us navigate what gaps we have in policy, and then they make recommendations on to the board. In terms of the outlook for health policy, we'll start with ACA fixes. At one point this past year, they were pretty close to agreement in the Senate. You had Alexander and Murray, election year politics got into the way here. But I do think there is an opportunity to revisit that. A lot of the work has been done on CSR funding, maybe some reinsurance. Subsidy cliff, that's additional tax credits for those people above 400% of the poverty line. That may be a little bit of a longer reach. Prescription drug prices, clearly this is an area where a Democratic leader, the Speaker in the House, and the White House may reach agreement on this, because this is such an issue that all Americans are concerned about. I think we're probably looking at a more modest level in terms of what might get through both chambers. Things like maybe stopping the games that are played with the patent laws, some more transparency, maybe the Medicaid rebates increase if prices increase above a certain threshold. Clearly, we've done a lot of work on regulatory relief, and we'll continue there. Some of that's been on the administrative side. In terms of the substance abuse issue, the opioid epidemic, clearly the pressure will be on coverage increases. Higher ed, this is where the student loan funding is authorized. They should have done this past year, and we'll have to address that in the coming year. And then you've heard about immigration, a lot of policy. Whether they can get agreement on a big immigration deal, I think is doubtful. But clearly we'll have to deal with DACA between the courts and the legislation. Clearly there are a number of other regulatory things that have come out of the Office of Civil Rights dealing with LGBTQ issues and immigration issues that we've engaged in administrative agencies where there was a backlog in visas being processed. We've engaged on those types of things as well. In terms of the challenges, I'm just going to focus on one thing here, and that's the budget. Congress years ago established budget caps. They set those aside this past year so they can spend more money for defense and domestic programs. This year, just on a one-year basis, they have to find $90 billion to put the budget together. $90 billion, there's not a lot of low-hanging fruit here. Now, they really want to cut a two-year deal, which means it's $225 billion that they have to find in order to get under these budget caps. And that's going to create some stress for the entitlement programs and some of the domestic programs that we care very much about. Our priorities haven't changed. Clearly, we are going to continue to advocate very firmly for expanding coverage, maintaining the safety net programs, making sure that there is better health equity in this nation, both within the federal, state, and also engagement with the insurers and outside of government. Some of these egregious insurance practices with a primary focus on prior authorization right now is a big part of our work. The opioid epidemic, I just want to stop here, and there's a project that Kai Sternstein is leading that we're going to be rolling out very soon, in which we've gone into just a few states, Pennsylvania being the first. Also, we've gone into Colorado, Mississippi, and North Carolina to do very detailed analysis of what the gaps are, and we engage the insurance regulators, the Medicaid directors, the behavioral health people, maybe the drug control office in that state. And the purpose here is to provide a playbook that we can share with other states so that they can make greater progress on the opioid epidemic. Gun violence issues been touched upon earlier. I think really what we're likely to see here is a push on our part and others for CDC funding. Maybe we can do something on expanded background checks, but you have to look at the reality of the numbers in the Senate, and I still think we're a long ways to go from being able to enact all of the AMA policy, but we will continue to push. On the delivery and payment side, I want to focus here. You've heard about the rule from Willie about the MIPS and the APM changes. We are undertaking a project to do a long-term look. It's probably going to take 2, 3, 5 years at what are the fundamentals of physician payment in the Medicare program. This is so important because Medicare drives all the other payer policies. And we know that the updates are inadequate. We know that the practice expense methodology probably doesn't reflect the cost that you all bear in terms of the electronic record burden that you have to support, the quality reporting that you have to implement, and there are other aspects of your practice. So we want to go on an evidence basis. We've got some outside people who are very interested in working with us to develop evidence to take to Congress and the administration to try to improve the payment fundamentals for physician and Medicare program. Now, we're in a very tough budget environment. We're going to have to find offsets for this. It's not going to happen overnight. But we're looking over the horizon here to try to make your practice environment more sustainable and put you in a position so that you have a sustainable practice that can look at some new payment and delivery models if you've got a proper margin to do that. I do want to make the point that in addition to the deference on the coding change, coding collapse, there was a very important decision also with respect to not going forward with multiple procedure payment reduction. Why this is important is that Jack Resnick and our health policy team had a big victory earlier this year with Anthem, in which we stopped them from applying this policy. The savings annually were $100 million just for the Anthem book of business. Now, because we got Anthem to not go forward, United Healthcare also didn't proceed with similar proposals. So very important that we didn't have Medicare sort of undercut, CMS undercut, the gains that we had in the commercial side of things. But we've got a lot of work cut out for us. The hard work is ahead. We're going to have to get consensus within the profession on any revisions to the E&M codes, and that's going to be some hard work, and we want people to come to the table as they have, and everybody's going to have to, I think, do some bit of compromise, and compromise is not a dirty word. There were a few things that we didn't like in the rule. I don't want to dwell on the negative here. I'm just going to focus on one thing. We maintain a work group that Margaret and her team leads, 2 work groups, one on MIPS and one on the APMs. Obviously, we want more APMs to come through the pipeline that was created by Congress through the PTAC, and we're keeping that dialogue going with CMS, and hopefully we're going to get a breakthrough in the near future. But what Margaret's team has done is try to come up with a scoring methodology that simplifies things for physicians so you got better line of sight for the MIPS side of the business, and also to make things more holistic so that when you are doing an activity that involves the quality reporting, that involves the use of electronic record, those things are connected in a way that you get credit across categories. So we know that the system, this MIPS program, is not perfect by any means, but we are working very hard to meet on a monthly basis with a team of people. Obviously, there's dialogue probably every day of the week with CMS on some aspects of this, but we're really pushing hard to simplify the whole MIPS process for physicians. Here are just a few proof points in terms of the value of AMA membership from an advocacy perspective. You heard the code collapse issue. This was going to be a huge hit to physicians across many specialties. We had the decision that was announced that was referenced earlier in terms of the decision in Pennsylvania for coverage of medically assisted treatment. That's a landmark decision we want to take to all 50 states. And we've also heard earlier today about the digital medicine increases, the policies that we've advanced to expand the ability to use telemedicine, but also to cover things in a physician's office like, virtual visits, interactions with patients, and consultations between physicians over the internet. The Anthem proposal that I mentioned earlier, Todd and his team were successful back in February to get legislation through Congress to allow us to have greater flexibility in the implementation of the MIPS program, because this is a 5-year implementation period. We were able to sort of soften the glide path for physicians with these amendments. We're also to be able to confirm that things like prescription drug, Part B administered drugs were not subject to the MIPS penalties. We've been able to reduce the quality reporting burdens. That's sort of a two-edged sword, because when we reduce the number of measures that CMS has in a drawer, sometimes we got to reduce the requirements, and we haven't been fully successful in that piece, but we're going to continue to press. People have probably forgotten that back in February, we're also able to repeal the Independent Payment Advisory Board, which was something that's part of ACA that we've been working for a number of years to remove. And you've heard earlier in terms of the huge number of victories that Kai and her team have been able to push forward with respect to at the state level. Just to keep you informed throughout the year, we put out every 2 weeks the Advocacy Update. This covers the breaking news on federal, state, and the judicial courts as well. Encourage you, if you're not signed up for this, it's free. You get great information to use with your colleagues and other activities. If you are not already a member of our grassroots network, please join. We have 2 levels to the Physician Grassroots Network. We have the regular level at the grassroots piece for physicians. Then we have a VIP group. These are people who have a definite relationship with a key member of Congress or any member of Congress. And so we provide some additional support for them to engage, help us when we're at 12:30 at night or over a weekend, we need to contact a member of Congress. These are the groups that have that kind of access. And we provide additional training and provide the source of information so you can be good advocates. Obviously, I'm not going to talk about the patient side, but we have 1.2 million patients in a network as well that we use to help us at the federal level. And finally, AMPAC, this is an investment in your profession. I know there are many AMPAC members here, but this allows medicine to support candidates. We run a campaign school that many physicians have participated in, and those graduates have gone on to state houses, statewide offices, the United States Senate, and in the U.S. Congress. Now we're up to 16 members, 16 physicians in the House, and a number of those people have gone through this process. But this also allows your advocates, your colleagues, to interact with members of Congress, to build relationships with them. And I can't stress enough how important this is for us to be involved, not just at the policy level, but also at the political level. And it's been a very effective program for medicine, and it's an investment in your profession.
That was Todd Askew and Richard Deem. Be sure to tune in to the other episode in this 2-part series about the AMA's advocacy and policy work. To get exclusive AMA advocacy news and information impacting physicians, patients, and the healthcare environment, subscribe to AMA's Advocacy Update newsletter at ama-assn.org/advocacy-update. You can also subscribe to Moving Medicine and other great AMA podcasts on iTunes, Google Play, and Spotify, or visit ama-assn.org/podcasts. Thanks for listening.